Symposium, one of the finest first global mechanical ventilation symposium conducted by Young India Intensivists, and all credit goes to you, Tapesh, for organizing such a wonderful academic feast online across different time zones and involving the best of the clinicians, researchers together. And what a pleasure for me to introduce this very, very important concept of physiological considerations in administration of IV fluids in mechanical ventilated patients and patients with pulmonary disease. And no other than Professor Dr. Manu Malbrain for this, who is regarded and very well known. Any amount of introduction on my part is like showing a little torch on a very great luminary, academician. But just for the sake of introduction, he is actually the head and professor at University of Lublin, Poland, as the head of anesthesia and critical care. Immense experience, a grounded clinician and an academician, and whose the claim to fame is basically as the president of International Fluid Academy, as well as he's the vice chair and steering committee of World Society of Abdominal Compartments Society, and has really worked on the ground to bridge the gap between the complex physiology and real world bedside care in fluid management. So without further ado, I would like to introduce and request Dr. Manu Balbrain to join. Unfortunately, because of certain unforeseen scenario, he has not been able to physically present, but he has sent and shared this recording of his lecture, which we can start from now. Thank you. Over.
Would like to slightly change the title of my talk to Physiology, Monitoring and Fluid Management in ARDS. And it is honoring the legacy of Luciano Gattinoni. I'm an internist intensivist from Belgium, working at a medical university in Lublin in Poland. These are my disclosures. So after a brief introduction, we will move to monitoring of the lung when we are giving fluids, and then talk about fluid accumulation syndrome, the importance of abdominal pressure, and then the management regarding the best fluid strategy. So it'll be a little bit about breaking some bad habits. Now, in the seminal papers on fluid stewardship in critically ill and perioperative phase, we proposed the ROSE framework, different phases: resuscitation, optimization, stabilization, evacuation. Now, within these four phases, they are representative for the four hits. Now, after the first hit, whether it's sepsis, burns, pancreatitis, we go for the resuscitation phase, which is for patient rescue. After early adequate fluid management, this is followed by optimization, focus on organ rescue based on ischemia reperfusion, where fluids are a biomarker for critical illness, and followed by the stabilization phase with a focus on homeostasis, organ support, aiming for late conservative fluid management, and then in those patients not responding, keeping a positive fluid balance, we need to aim for organ recovery through late goal-directed fluid removal. Now, within acute illness, there are fluid shifts, and these are dependent whether or not the endothelial layer with the glycocalyx and the tight junctions are normal or damaged due to sepsis or any other insult, as this will lead to fluids leaking into the interstitial space. Now, this will affect lymphatic drainage, oxygen diffusion, because the distances will be higher, as well as diffusion of metabolites. So fluid accumulation syndrome has to be avoided by all times. Now, fluids can be drained from the lungs through the hilus, transpleurally, or transabdominally through the lymphatic duct. Now let's have a look how mechanical ventilation will affect heart-lung interactions. During inspiration, there is an increase in pleural pressure and transpulmonary pressure, and this will result in a drop in RV preload and increase in RV afterload, and this will then result during the expiration in a drop in left ventricular stroke volume. Now, at the same time, the increase in pleural pressure will result in a drop in LV afterload and an increase in LV preload during the inspiratory cycle, and this will result in a maximal pulse pressure during inspiration. Now, these mechanical ventilation effects on preload and stroke volume and pulse pressure form the basis for assessing fluid responsiveness. Now we know that hypovolemia is bad. That's why the prediction of fluid responsiveness is important, or maybe instead otherwise the prediction of fluid unresponsiveness. And this can be tested via different methods, and they are summarized in this paper published together with Xavier Moon and Michael Pinsky, each test having different thresholds for positivity, different indications, tips and tricks. Now, hypovolemia is bad because we have a perfusion problem. Oxygen can't get to the tissues. But hypervolemia, as already mentioned, may even be worse because here we have a diffusion problem. Oxygen can't get to the tissues because of an increase in diffusion distance and other problems like intra-abdominal hypertension. Now, moving on to monitoring, and this is my personal preference for monitoring tools. First one being transpulmonary turbodilution. This allows us to instill a cold bolus of saline on the right side. This will go through the pulmonary circulation, and then the cooling will be detected at the femoral site. This is an example of a bit strange transpulmonary turbodilution curve with an initial hump, then getting back and then a second hump. This is what we refer to as the double hump curve or the camel curve. Now, transpulmonary turbodilution is important and interesting because it gives us information of preload, afterload, contractility, dynamic parameters like ppv-SVV, as well as organ function. And here comes the lung water. Now, this transpulmonary turbodilution curve can be explained by the fact that in ARDS or right ventricular failure, there can be increased pressure at the right side, thereby opening the foramen ovale. So some of our thermal indicator will directly go from the right to the left side circulation via the foramen ovale, and the rest of the bolus will follow. Now this helps us to identify a shunt fraction, and this is what has been referred to as the camel curve. Now, this is a pint of beer, so it's half a liter. Now, pulmonary edema is any abnormal accumulation in the extravascular space. So normally we have around half a liter, and if you would add 200, 300 ml on top of that, patient would be in over pulmonary edema. Let me put this in perspective. This was the Bush Sharab, where there was a tennis match, and you can see the size of a tennis court is more or less like the surface of the lung. The lungs are normally a pretty dry space. Dry lungs or happy lungs, this is needed for recruitment, diffusion of gases. Now we see that mortality increases when the lung water increases. So this would mean if you would add half a liter on the surface of a tennis course, then the patient would be in overt pulmonary edema with morbidity and mortality. Now, systematic reviews have shown that extravascular lung water is an independent predictor for mortality, as you can see in this systematic review. Now, survivors have, on average, a lung water that was 5 milliliter per predicted body weight lower. Now, other things is that can we follow up on the lung water in relation to fluid balance? Now, in this observational study, we found that patients who have a drop in the lung water have a better prognosis. We define them as a responder, and you can see that the responder, the ones where lung water drops, have a cumulative fluid balance more in balance than those who do not respond, who have a much larger positive fluid balance. Now, late conservative fluid management, which is 2 consecutive negative fluid balances within the first week, resulted in better survival and faster weaning. Now, the responders, those who drop the lung water, also better survival and faster weaning. Now, another interesting parameter is the PVPI, the pulmonary vascular permeability index. On the left, we have hydrostatic edema. On the right, you have hyperpermeability edema, which is what we see in ARDS. Now, the higher the PVPI, the more indicative for hyperpermeability edema, like we see in ARDS. And the cutoff seems to be around 3. Now, that is why in secondary ARDS, where abdominal pressure is increased due to bowel edema, ileus ascites, that we can send a PEEP to counteract the IAP. Now, we know the paper from Luciano Gattinoni during COVID talking about L and H phenotypes, low and high elastance and lung properties. At the same time, we published with Paolo close a paper on ventilation in abdominal hypertension and the squishy ball hypothesis. Luciano focused on lung characteristics, elastance, right to left shunt with LNH phenotypes. And the squishy ball, this is a squishy ball. If you squeeze it, you see some parts will be distended on the side. This represents the heterogeneity of alveoli within ARDS, and comparing the lung resting and the open lung approach, you see that the difference is that we need higher opening pressure at the risk of hyperinflation at some regions. Now, in our paper looking at ventilation abdominal hypertension, we suggest LNH phenotypes in relation to IEP, body mass index, cumulative fluid balance. So when we combine these papers, maybe there are not 2 phenotypes, but 4, and maybe there are more, as we will discuss later on. Now, what about the fluids? Well, we have to bear in mind that we think about the reason why we are giving fluids is either to promote stroke volume and thereby tissue perfusion so that oxygen-rich fluids can get to the tissues. We should only give fluids when patient is in shock, when there is hypovolemia, tissue hypoperfusion, like in capillary refill time that's increased, or a lactate. Patient should be fluid responsive, fluid tolerant, and not at risk for fluid accumulation syndrome, which may be the case if there is ARDS and capillary leak in the lungs. Now, fluid accumulation syndrome is a syndrome, not a disease, but many colleagues don't pay proper attention. Let me illustrate with a typical case of abdominal sepsis, perforated viscous after surgery in the ICU, and the patient may receive a bag of saline because low blood pressure, CVP, urine output, maybe PPV is positive, or and expiratory occlusion test is positive, or the passive leg raising is positive. Why? It's kind of a reflex. Whenever something goes wrong, we feel that giving 1 bag of saline is probably not harmful. On day 2, distended abdomen, increased pressure, and on day 4, a positive cumulative fluid balance. Oliguria CVVH is started because of secondary ARDS in relation to the abdominal hypertension fluid accumulation. By day 7, there is acute circulatory failure, cardiac arrest, decompressive laparotomy, and there is acute mesenteric ischemia. Now, the question is that we know that abdominal hypertension is a killer, but the question is, are we shifting our mindset, thinking about fluid stewardship, and are we doing everything to prevent fluid accumulation syndrome, especially in patients with ARDS as dry lungs or heavy lungs? Now, a recent definition is any increase in body weight or cumulative fluid in relation to the admission body weight or the baseline body weight. So either a change in weight or cumulative fluid balance, but we know it all is potential pitfalls. We know that fluids are mainly in the intracellular space, whereas only 1/3 is extracellular, out of which 1/4 is the intravascular volume. When we talk about fluid accumulation, we speak about an increase in extracellular water. Hypervolemia is the opposite of hypovolemia, is an increase in the intravascular fluids. And probably the relation or interplay between fluid responsiveness, non-responsiveness, tolerance, intolerance will determine the risk for fluid accumulation syndrome. And we have to remember that fluid responsiveness does not mean that the patient is fluid tolerant. Now, fluid overload or better fluid accumulation may lead to an impact on all organ functions, not only at the outside with anasarca, but also at the inside with venous congestion and venous hypertension, and what we refer to as this global increased permeability syndrome, also in the lungs. Why? Because fluid overloading will lead to hypervolemia and hydrostatic peripheral edema. The opposite is not true. It's not because you're edematous that you're hypervolemic. And that's why Jean-Louis Vincent suggested to avoid the term fluid overload. Everything you need to know can be found in this paper on deep resuscitation, as well as this free open access review on fluid accumulation syndrome. This is the visual abstract. So it is endothelial glycocalyx damaging, the pathophysiology and organ congestion, venous hypertension, and it will impact all organ functions. Now, the key is restrictive fluid therapy, maybe withholding, withdrawing, so the de-escalation part, or active fluid removal, which is the de-resuscitation part. Now, why is this important? Because fluid balance acts on mortality. In the systematic review was shown that those who are doing pool have cumulative positive fluid balance. In hypothesis generating paper, with Paolo Pilosi and Patricia Rocco, we develop fluid management strategies and how they interact with mechanical ventilation and how we can take it from interventional animal studies to the bedside, so to translate it. If you have positive pressure ventilation, we have an increase in the pleural pressure, in the airway pressure, and this will result in a drop in transmural vascular pressure and peripheral edema. So RV preload will be reduced, the afterload increased, as we already mentioned, and this will result in less edema because of a drop in transmural vascular pressure and a drop in transvascular filtration pressure. So the positive pressure ventilation acts as a left ventricular assist device and squeezes the fluid out of the alveoli to the left atrium. On the contrary, when the patient is doing spontaneous mechanical ventilation, we will see increase in the transmural pressure and an increase in the edema formation because of an increase in RV preload due to the negative pleural pressure and the suctioning of blood into the thorax. And this may result in increased transvascular filtration pressure and pulmonary edema, and what we saw, the P-cili or the spontaneous breathing induced lung injury. So this we need to bear in mind when we're talking about fluids mechanical ventilation, ARDS, but not to forget intra-abdominal pressure. Typically on the chest X-ray you see the diaphragms towards the baby lung approach, the high intrathoracic pressure. Now after intubation recruitment we set the PEEP to counteract the effects of increased abdominal pressure, but in a typical patient, like for abdominal sepsis, you can develop a secondary ARDS with increased lung water over the days. So fluid accumulation syndrome in setting of abdominal problem like the primary compartment syndrome and perforated viscus go hand in hand with extrapulmonary or secondary or also called surgical ARDS. So I think it may be time to go for continuous intra-abdominal pressure monitoring, as esophageal pressure monitoring is not that easy. There are many reasons, and nowadays there are specific techniques like the trauma guard with 3 balloons that allow continuous IAP. Bladder monitoring connected to a smart cable gives you a 24-hour reading. You can now analyze what is the maximum, the minimum, the delta, what is the index of transmission, abdominal pressure variation, and so forth. During different intervention patient to CT, then there was paracentesis performed, and then there was abdominal bleeding with again an increase in the pressure. And with analysis, we can look at pressure, time, burden, area under the curves, and so forth. Continuous IAP monitoring is also interesting to understand organ-organ crosstalk information, like in this patient where there is a fighting with the ventilator with increases in abdominal pressure that are resolved by giving neuromuscular blockers. So moving on to the last part, which is about the management and fluid management in ARDS, the difference between normal lungs and ARDS lungs with increased permeability of the alveolar capillary barrier, leading to protein-rich fluids in the alveoli and interstitial edema. John Silverside performed a systematic review meta-analysis looking at 49 papers comparing conservative versus liberal fluid management. Overall, there was a trend to improved outcome and mortality in favor of conservative fluid management. At ventilator 3 days, here there was a clear favor of conservative fluid management that was statistically significant, as well as length of stay. So we can say that in adult children with ARDS sepsis, a conservative or deresuscitative fluid strategy results in increased number of ventilator-free days and decreased length of ICU stay. The effect of mortality was uncertain. And you're probably all aware of the FACT trial comparing 2 fluid management strategies with a primary outcome of 60-day mortality, where there was no difference in primary outcome. There was a significant difference in ventilator-free days, as well as difference when it came to dialysis in favor of the conservative group. So here we can also state that despite the fact there was no difference in 60-day mortality, conservative strategy improved lung function and shortened duration of mechanical ventilation. Now, in this guideline on the management of acute respiratory distress, regarding the fluid management, there was a PICO question whether conservative fluid strategy affects survival. And here we can say that in adult patients with ARDS, clinician should consider the use of conservative fluid strategy, maybe with use of fluid restriction, withdrawing, withholding, de-escalation, and de-resuscitation with diuretics, and possibly hyper-oncotic albumin, 20%. And this was also ESICM fluid guidelines on de-escalation. Now, within the FAT trial, there were identification of different phenotypes. Phenotype 2 was the inflammatory phenotype, and you see that there the vasopressor use was more increased. So when we look at the impact of the phenotype on 90-day mortality, then we see that the inflammatory subphenotype 2 performed better when it comes to liberal fluid strategy, which is a bit counterintuitive. So in conclusion, we can say that different ARDS subphenotypes respond differently to randomized fluid management and maybe different treatment approaches. And this is something important that we need to bear in mind when we want to aim for precision medicine, identifying the unique patient for the unique management when it comes to fluids, diuretics, presses, or adjunctive treatments. So when it comes to fluid management, we need to identify those patients that will benefit from restrictive versus conservative fluid management, and those that will be harmed. By all means, there is no place for abnormal saline. It increases sodium balance, increases chloride levels, diminishes renal perfusion, creates acidosis. With the sodium balance comes a fluid balance, increase in potassium, higher risk of AKI, and more vasopressor needs. Now, if we look at the Rose framework, again, we can say that during resuscitation, isotonic balance crystals are a good first choice. We should avoid maintenance when not needed, limit fluid creep by avoiding sodium and chloride, aim for hypercaloric enteral nutrition. Remember, all fluids are redistributed. It's just a matter of time. At the very end, for de-resuscitation, we could think for hyper-oncotic albumin 20% after initial large dose crystalline 30 ml per kg. Think about restriction, de-escalation, withholding and withdrawing of fluids, and maybe in some patients there is a place for de-resuscitation with diuretics or CVVH. Saline has still a place in TBI and neurocritical care patients. So to wrap things up, ladies and gentlemen, I would like you to go home with the knowledge that dry lungs are happy lungs. The lungs are a pretty dry place. Mechanical ventilation by itself impacts fluid management, volemia, and fluid responsiveness. ARDS benefits from restrictive fluid regimens, but we need to monitor, and my favorite would be extravascular lung water, PVPI, abdominal pressure, maybe in the future, PIA, and electrical impedance tomography. There's an urgent need to recategorize heterogeneous syndromes, and we know that different management is probably needed for different phenotypes, as well as for patients with secondary ARDS and abdominal hypertension. Take care of the lymphatics, as they are the hydraulics of your body, and avoid iatrogenicity, limit sodium and chloride, as well as fluid accumulation syndrome. Having said that, I kindly invite you to join the International Fluid Academy with a lifetime free membership, and we see each other maybe beginning of December for the 15th anniversary International Fluid Academy Days. Thank you for your attention.
Dear Tapesh, am I audible now?
Yeah, I'm just 1 minute.